My name is Naomi Cameron, and I am professor and vice chair in the Department of Mathematics at Spelman College. I'm also a past vice president of the National Association of Mathematicians, otherwise known as NAM. And it's my pleasure to welcome you to the NAM Claytor-Woodard Lecture. NAM was founded in 1969 with the mission and purpose of promoting excellence in the mathematical sciences and promoting the mathematical development of all underrepresented minorities. NAM established the Claytor-Woodard Lecture in 1980 in honor of Dudley Woodard and William Claytor, the second and third African Americans to earn a doctoral degree in mathematics. I am honored today to be able to introduce the 2022 Claytor-Woodard lecturer, Dr. Monica Jackson. Dr. Jackson has been professor of mathematics and statistics at American University in Washington, D.C. since 2005, where she now serves as deputy provost and dean of faculty. I've known and admired Dr. Jackson since the mid-1990s, when we were both graduate students at the University of Maryland, College Park, and part of our own historic cohort of students, whom, like myself and Dr. Jackson, came from HBCUs in many cases to attend the graduate program at the University of Maryland under the visionary leadership of Dr. Raymond Johnson, and where Dr. Jackson ultimately earned her PhD in applied mathematics and scientific computation. Her current research interest is in the area of spatial statistics and disease surveillance, with applications to developing, investigating methods for detecting cancer clusters, global clustering patterns, and developing simulation algorithms for spatially correlated data. After receiving her PhD from Maryland, Dr. Jackson went on as a postdoctoral researcher at Emory University, and she spent several sabbaticals at institutes around the country, including the National Cancer Institute, the Institute for Pure and Applied Mathematics at UCLA, and Statistical and Applied Mathematical Sciences Institute, where she worked on applying her spatial techniques to a wide variety of medical problems. She's won numerous awards for her scholarship and service. Those include the Frederick Douglass Distinguished Scholars Faculty Fellow, the Delta Kappa Gamma International Education Society Most Valuable Member, and the Morton Bender Prize for Outstanding Research. At American University, she has served as an Associate Dean of Undergraduate Studies in the College of Arts and Sciences, and as the college's first Diversity, Equity, and Inclusion Officer. She established American's first summer program in research and learning, where undergraduate students and faculty from across the country conduct scientific research. She is also a principal investigator for American's Advance Grant, analyzing gender and racial data, and working to increase equity in these areas among STEM faculty. So I'm delighted to be able to turn things over to Dr. Jackson so that we can hear about her research. I'll take this opportunity just to remind the audience that we will have time for questions at the end of her lecture, but you're welcome to place your questions in the Q&A at any point during the lecture. So without further ado, I give you Dr. Jackson. She will be speaking to us today about applications of spatial data analysis to public health data.
Thank you so much, Dr. Cameron. I appreciate that introduction. And yes, we go way back those Maryland days. But thank you. I'm honored to be here to be a speaker for the NAM Claytor-Woodard address. Clayton and Woodard were exceptional mathematicians and did a lot for the community. So it is an honor to be able to give this talk. This also is extra special for me because I have been involved with NAM for a very long time, since I was an undergraduate student. So it's nice to be able to give this lecture and follow in the footsteps of many of those that came before me. So what I'm going to do, I'm going to talk to you a little bit about my research area in spatial statistics. And so I'll give a little background introduction about what actually spatial data is and what spatial data are about, and I'll talk about some of the problems that I solved. And then I'll go through an application of a spatial data analysis project that I worked on with a group of students that were part of my summer program. So first, a little bit of background about me. So all of my degrees are in math. But I do statistics now, and statistics can be broken up into two groups: to apply statistics and more the theoretical mathematical statistics. So I do more on the applied side now, and I do more work into public health and medical applications. But in my field in spatial stats, we study a lot of different problems. I mean, spatial stats applies to almost any field, but I'm most interested in health issues. And so you'll see questions like, I have here is AIDS less prevalence, one goes from the east to the west. Do socioeconomic stats affect the occurrence of sudden infant death? And even public health questions like what type of diets really make you skinny? All of this can be studied using spatial data analysis. As Dr. Cameron mentioned, my research my background has been in many forms. I've spent sabbaticals at a lot of institutes, National Cancer Institute, at IPAM. I've worked at the Uniform Services Health University. I've worked at Xerox and Motorola, a lot of places where it's kind of helped shape my interest in this field that I'm in now. So let's back up. I want to talk to you a little bit about what I actually do, the type of problems that I study. So my work in spatial analysis centers around disease surveillance. And there's many definitions for disease surveillance, but the one that I mostly use is the tracking, analyzing, and preparing for outbreaks. And so, of course, very timely right now because we're actually in an outbreak, but I'll break through what each of those terminology actually mean. So the tracking part is the collecting data. The analysis part is based on using mathematics or statistical methods to actually analyze the data. And the prepare might be to alert medical facilities so they can be ready for what's to come. And so why disease surveillance? Again, we're in COVID-19 now. That's a clear example of why it's necessary to do this. But we've been doing this for a long time. That's how we know when cold and flu seasons are coming. It's how we know when there have been food outbreaks. You've seen in the news sometimes whether you'll have a recall of certain foods because they found something in the plant or something. But the goal is always to prevent or contain outbreaks. Now, the work that I do relies heavily on data, and the data that I study are collected in a variety of modes. The most common form of data that I use actually comes from registries. So for example, if you go to the doctor and you're diagnosed with certain diseases, such as certain cancers, heart disease, things like that, you're automatically put into a registry. And this registry has a bunch of information that doctors and researchers use to study trends in the cancer. And so it has info on, say, your marital status, your health status, your basic stuff as your gender and weight, things like that, where you live. All that's used to track the spread of certain diseases. Another form of data is OTC, that's over-the-counter medications. A lot of people don't think about these data sets, but a lot of you go to a grocery store, you have those little cards or a rewards number that they actually put your phone number in. They give you, some money off each time if you do that. Well, the reason they do that, that's actually another database, and it's a good data set that's being collected because they're tracking what you're buying. And so if you're buying a lot of certain type of medicines, it might be an early indicator that something's about to happen. A good example for this, how this was used not too long ago, was during the Super Bowl, the infamous one where Janet Jackson and Justin Timberlake performed. Right after that halftime performance, there was a spike in over-the-counter medicines and antacids. So immediately everyone thought, like, oh, something had happened. There was some bioterrorism outbreak, something was put in the stadium, but it was actually the opposite. There actually was a commercial that aired right after. That was some Pepto-Bismol commercial or something. And so people ended up buying the medicine, they ended up buying the medication, which again caused a spike in alert health facilities that there actually might be something going on. So it's a good data set, it's an early indicator data set, but there are definitely flaws in it. School absenteeism is another one that's studied by researchers. Again, in public schools, we track your attendance. And so a lot of students end up missing on the same day. It might be a signal that something's going on. ERs, the emergency room data sets. And in those data sets, again, those are great ones, again, early indicators of something going on. However, they're not really great data sets because when you're in an emergency situation, something's happened, no one's really paying attention to how they're entering those data. So it can be really messy data. So it's really hard to clean those data to actually use them in the proper way. here's an example of what an outbreak, just a basic figure when it happens in an outbreak. And so my x-axis I have time, y-axis I have the occurrence of some disease. And so what happens is you have one group of the population, which is the bottom curve, that gets sick, not really sick, but they get sick and they get better. But it's the second wave of population that gets sick much quicker and stay in much more, the population gets sick. That's when it's symbolizing that we actually have an outbreak or something that's happening. So it's that mark point where those two populations cross and where we're trying to actually identify when the outbreak is about to occur. Now there's different types of spatial data. I study what's called discrete spatial data. So I look at count data. So count data like the number of people with a certain disease. And in my data, I look at aerial data, regional data. So here I have a map of North Carolina divided into its 100 counties. So when I study spatial data, I look at data that's aggregated over the region. So divided into these counties, I might use zip codes or some other boundary. The idea is that data that are closer together in space or by location are more related to data that are further apart. You know, one easy example to look at this is like if I were to plant a flower, say here I'm in North Carolina right now, if I plant something here, has no bearing what would happen if I plant that same flower, say in California. But if I plant a flower here and planted one of my neighbor's yard, you know, would have the same rainfall amount, same soil type, so there might be some correlation there, which would determine what the yield will actually be. So why is there an interest in these type of data? For one, again, you're seeing it now with the COVID-19 pandemic. You can study trends. So maybe there might be east-west trends related to, say, maybe where you live, based on, say, socioeconomic status in the country, different trends that exist because of the actually geographic location of where you are. And these data, these methods, they apply to all kinds of different types of data. I'm just most interested in medical and public health applications, but they've been utilized in several other fields. So I mentioned earlier the difference in analyzing regular classical statistics and the type of stats that I do is that the correlation. So in the data that I study, the common assumptions in statistics and data analysis is that you have independence. So one observation has nothing to do with the other observation. That's not the case in the data that I actually study. There is some type of correlation that's based on the geographic location. So if I have a cold and I sneeze, and maybe someone around me, my family member, might actually get the cold if they're close to me, but no impact on someone that's several houses down from me to have no interaction with me. And so there's different types of correlations that actually happen. You have positive, negative, or no. So in my work, when I look for spatial autocorrelations, so I mentioned I study regional data. So you take some region, you divide it up into sub areas, and I look at the aggregated counts that happen there. Here's an example of data that may have a positive spatial autocorrelation. So let's assume the reds are the high values, the greens are the low, and the yellows are the intermediate value. So what you're looking for here is that high values are near high values, so the reds are together, low values are near low values, so the greens are together, and the intermediate are near intermediate values. So say if you're looking for an outbreak, you may look for the clusters, so the high red areas. We also have negative spatial autocorrelation, which is the exact opposite. So you might have high values surrounded by low values, which would be the reds right next to the greens, and the vice versa, low next to the high, and the intermediate values by intermediate values. So you see this negative correlation happening sometimes in regions, say, such as in cities that are bigger cities that are surrounded by smaller cities. So in New York City, people who live there in New York City, say there was an outbreak there or something, that may have an impact on people that live in the surrounding areas, not in New York City, but some surrounding areas in Rochester or someplace else. But the converse might not be true. If they're an outbreak in some of the smaller areas around New York City, may not have any impact on them in New York City. And that is because how people would travel. It's more likely some of the surrounding areas may go into New York City than vice versa. Okay, so I mentioned that the work that I do is a lot different than classic standard statistics methods. So those of you who've done stats before, you've seen these plots that I have down here. These are just basic scatter plots. On the first one, the x-axis is showing education. The y-axis is showing income. And so you see a positive relationship happening, meaning the more education that you have, possibly the higher income that you would have. Well, in spatial statistics, the work I do, there needs to be some relationship that's shown by a region. So some nearby, some geographic variable has to happen. So now I have on the x-axis, I have education. But on the y-axis, I have education of your nearby areas, or people who live within the same distance of each other. And so interpret it a little bit differently when you look at scatter plots that represent spatial data. So in this one, where I see this positive correlation, it is just showing that the closer people live together, or the more people together, the education is around the same. So slightly different the way which how you interpret classical statistical methods. Okay, so what happens in spatial stats is, again, a lot of data sets have a spatial component to them, where spatial correlation exists. And sometimes it's also not used. People may treat it as if it's independent. And that's because we have a lot of methods, a lot of statistics, a lot of ways to analyze data that are independent. Not so much that data if there is this spatial autocorrelation that exists. But it becomes a problem if you have a data set that has some type of geographic correlations or spatial correlation, and you analyze it using traditional statistics methods, you kind of get fooled twice in it. For one, the basic correlations, how that I showed you before, you're going to think you have a correlation when you actually don't. And the second, you're going to think your correlation is actually stronger than it actually is. So it is important to do, if you think you may have data sets that they're in some type of correlation, that you kind of do the extra steps to rule this out before you use classical statistics methods. So I want to show you just some maps. So again, my work, I produce a lot of maps. I study geographic trends and data. I do a lot of visual displays of data. This map, this is based on a study that I did in California some years ago. And in this map, we were studying mammography screening rates in California. The reason we were looking at California, because for one, California has one of the highest screening rates for breast cancer. It's over, I forgot 5 times, it's around 85 to 90% of women follow the health screening guidelines to get screened for breast cancer on time, which across the country, that the average is close to around 60%. So we were studying in California why is screening rate so high there, and hope to possibly see how we can kind of correlate that to other states to help them have higher screening rates. Well, in this study, again, it was a long study, but one part of it is I produced this map to see here. And in it, you see the screening rates in California. And I divided the region into counties, zip codes, and these MSSA areas, which are these medical, I forget the exact acronym, but these medical service areas that are divided up in California. One thing we noticed too that's in doing, again, spatial analysis, again, you're looking for geographic trends, you're trying to find out why you have these geographic trends. Well, this study was interesting because after observing it, we see that if you compare the map that I have on the right, that is just where we define California based on its rural and urban area. So the lighter areas are the urban areas of California. The darker areas are the rural areas of California. For one, that's the first trend you see, is that the screening rates are highest in the urban areas of California. The second thing we notice, you see we have this highway down kind of California. Just to look, I had an economist that was helping me with this project that noticed this, that we see that the rates are actually highest for people that live along these highways. So we spent a lot of time looking into that, why that might be the case, and we came up with that. For one, it's the traffic trend. So California, as you know, especially in LA and some of the more urban areas in California, have a real problem with traffic, and it seems as though people are more likely to get screened for cancer screenings if they live near a highway versus if they didn't. So women in the urban areas would get screenings, they had more access to different types of transportation versus living in rural areas where maybe they didn't have access and didn't have so many highways. So that became an important predictor when we actually studied these data. Here's another map that I looked at some years ago. This one we were looking at colorectal cancer screening rates. So in this map, we were looking at the difference between the mortality rates for Caucasian, we complain. So we took the national average, subtracted it from just Caucasian mortality rates, and you see not much of a trend. The national average is about the same because it's all red. But compare it to African Americans subtracted from the national average, you see the color change a little bit. So this map doing this shows that there's discrepancy in people who actually get colorectal cancer, not just based on their race, but by where they live. So this map actually pulled out areas that had higher mortality rates for people that were diagnosed with colorectal cancer. I mentioned earlier that I study clusters, I study global patterns. Here's an example of a global pattern of a disease data set. This is actually HIV mortality rates from 1982 to, I believe, 89. And what you notice here, I don't have the legend on here, but what you notice here is that the higher rates, the higher mortality rates happened along the coast. So, and you see this kind of rainbow effect happening. So as you go from the south to the north, the rates tend to decrease here in this map. That's a global spatial trend that you see. That's based on geography. In the work I do, I find these trends and you try to figure out why these trends are actually happening. There's another problem that I worked on where we were studying leukemia rates. This is a study that was done first at the National Cancer Institute, and it was predicted that leukemia mortality rates were highest if you live near a nuclear plant location. So there were something like 100 something nuclear plant locations in the United States. We had marked them. We did analysis and we were looking to see if there were any clusters near them. And actually the opposite had happened. The rates were actually lowest near these sites. And again, after further examination, we're looking at these, and a lot of researchers have studied this. The reason being for that is that people who live near these sites, they actually know that they live near these sites. So they do everything else in their life right. So they eat right, they get 8 hours of sleep, they wear a seat, but they do everything they have control over, they do. So they end up being very healthy and strong people. So they end up being able to survive much better when they do get diseases. And so their actual mortality rates were actually a lot lower there. Okay, so those are some examples of some of the studies that I've done in past in spatial analysis. So now I want to talk to you about a more recent one that I did with a group of students that was right when the pandemic was starting in 2020. I was leading a undergraduate research experience program called Spiral, which I'll talk to you about a little bit later. And the program we just started in June. And of course, you know, the pandemic, we went on lockdown in March. And so, you know, as a spatial statistician, COVID data set is a classic spatial data set that spatial statistician would want to study. And so students actually developed an interest in it. So we kind of shifted our project to look at this. So some background, everyone knows by now what COVID-19 is. And you know, back when it was first came out, when New York had its first confirmed case in March, we weren't clear about the spread of this. You know, everyone thought you could get it by touching surfaces. Later on, we found it was more respiratory, it was in the air. So there was a lot up in the air going on about that. So we were looking at different causes of who was getting disease and why, and who was not surviving from the disease. So when we first started these analysis, so this is again by June 30th, 2020, the program just started on June 6th, and so we collected data. And again, we were focused on New York City, because remember at the time, that was the epicenter in the US for the disease. There were 18,000 deaths and over 212,000 cases. Well, we all know as of today, we've had close to 1 million deaths now and close to 81 million million cases. So of course, the disease definitely spread pretty quickly in these past 2 years. But we were working at the very early stages when the data were just coming in, when the data were completely raw and coming in. So what we were doing, we were trying to find out what were factors, what were predictors of COVID-19. We were studying New York City again because it was the epicenter of the disease at the time. And New York, now and at the time back then, has a lot of racial disparities across the different boroughs. And so we were looking at those differences of racial disparities along with other factors that we thought might be predictors of who was getting disease, who's being treated, and who was not having great outcomes from disease. So we looked at several variables. There are several disparities between the boroughs in New York City. And so back at the time when we're first doing this, the Bronx was leading in death and hospital rates for COVID-19. Manhattan, which was more wealthier area in New York City, they had the lowest hospital and the lowest death rates of COVID-19, even though their case rates were still going up just as they were in the other boroughs. So we were looking at differences between these boroughs to see if the social demographic characteristics were impacting COVID-19. So our basic problem that we were studying, we were determining which factors were most predictive of COVID-19 case rates and death rates in New York City. And they were looking at potential differences and predictors between the boroughs and also within the boroughs. So we did a two-stage analysis for this. We did a model where we looked at all the cases and mortality rates in New York City. And we also looked at the differences in between boroughs to see if we could see those differences, say, between the Bronx and Manhattan. So our methodology that we went about doing this. So we did, I'm not going to go into the deep details of the models, but we did a spatial regression analysis for these data, and I'll show you a map later on of why we had to do that. But our response variable was we had the cases and the death rates. And this is what we collected on July 2nd of 2020. So again, remember, this is very early data that we had at the time. We looked at a number of predictor variables. Again, data was so new. We were just beginning, a lockdown. We were trying to figure out what the predictors were. So we spent a lot of time collecting data and getting access to a lot of New York data. So here are the variables that we had access to. At the time, the outcomes in the news, they were saying age was definitely a predictor. So people that were older were getting disease more likely, and they were having worse outcomes. Race was a variable that we looked at. We looked at citizenship, income. Some interesting variables looked at were mobility index. So this was how people actually move through the city. So LA has a very high mobility index. So meaning people are athletic, they get out, they walk more than say they live in DC, where people have more sedentary jobs. And one reason for that is because the weather is by far much better in California than it is in DC. So people get outside a little bit more. But we had other variables that on this circle here, we had some weather variables. We looked at the number of people that say that had asthma, we looked at the ozone layer, we looked at obesity, we looked at poverty, how close you live to a grocery store. A number of different variables we looked at to see what were predictors of COVID-19 cases and death rates. So in our method, we did a multiple regression, we did a spatial regression analysis, and then we started out first doing a correlation test. Because we had so many variables in our model, we wanted to first determine which ones were the most important variables to actually include in our models and which ones we could actually remove from our model. All the analysis that we did was done in R and B. And again, I'm not going to show you everything, but we did make sure that all the assumptions were met to do our analysis. To do a spatial regression, there are additional assumptions that you have to make besides the classic regression assumptions that are typically used. And so we went through all of those of showing that there actually was that, in the very beginning, I showed you what it looked like to have a positive or a negative spatial autocorrelation. So we did all the tests for that to see if that was there. But then we created a bunch of maps also that I'm going to show you. Okay, so let's go through some results. So I mentioned a few slides ago that we had a number of variables, and then in any type of analysis, you don't want to have, if you're going to have a lot of variables in your model, you don't want them to be highly correlated with each other. that happens, you get confounding, you can get some incorrect results, especially in spatial analysis. You don't want this to happen. So we checked for correlations, and the percent poverty was correlated with several variables. For one, it was correlated with the percent of people that were on food stamps, and that was expected. It was correlated with the percent that did not have a high school education, and the percent that had asthma that related in that caused, say, emergency room care. So because of that, the poverty variable was removed from the model. It also was expected that we had some of the weather variables, so the percent particle matter and ozone were highly correlated. So we ended up removing the fine particle matter. And another interesting correlation that we had was the mobility and the ozone were highly correlated. So the more people were mobile, the higher the ozone layer was. And so we couldn't actually explain it one, but we couldn't have both in the model. So we ended up removing the mobility index. Okay, so this is our first map that we created. And this is the one with the cases. So we looked at cases per 100,000 residents by each of the boroughs. And it's broken up, so each dot represents a zip code area. So the interesting thing, if you notice here, is that the Bronx has the highest cases from this map that we have of the boroughs in New York City. And Manhattan still has the lowest that we're seeing from this map. So the next step, again, so again, showing that you do see some type of spatial trend that's happening. So next we ran a spatial regression model. And so we did two models. We did a full model that was not stratified with all the data together. And then we did a stratified model, which broke it up with the different boroughs. So this, looking at this table is kind of hard to kind of see what's going on. So let's look from here. So this is the full model with, well, let's look at the first one. The first bar far to your left is the full model. And all I did here, we pulled out the variables that were significant. So the percent, so what this was saying was a positive coefficient. So the more people that were over the age of 65 in a region, the higher the COVID case rates were in that area. The percent white and negative coefficient, so the higher the percent white that were in the neighborhood, the lower the COVID cases were. And then we see some other variables. So the higher, the lower the number of grocery stores for this, they had a negative coefficient here, the higher the COVID case rates were happening. And so again, with the non-stratified model, so the full model, we had several variables that were significant together. The interesting thing happened, we broke it up. So we looked at the boroughs separately. So we looked at Manhattan, the Bronx, Staten Island, Queens, and Brooklyn separately, ran them individually as spatial regression models to see actually which ones were, what variables were predictors and which ones weren't. And again, based on the maps that I showed you on the previous slide, we knew that the Bronx had the highest case rates, but Manhattan had the lowest. Very different variables were predictors of COVID-19 cases there. So in Manhattan, the percent older was, so the higher the age in the region, again, the higher the COVID rate, and also the citizenship here. So the higher percent of non-US citizens, again, the higher the case rates for Manhattan. And the Bronx is percent white and the percent on food stamps. Both had negative coefficients in there. So separating the models out, separating the data out separately, you kind of see a different trend that's happening. Now we looked at the death rate. So we did the same analysis. And so instead of looking at the COVID cases, we were looking at the death rates. And so in this, again, we see the same trend and looking at all the boroughs in New York City. Still what we see here is that Bronx still has the highest death rates and Manhattan has the lowest death rates. And again, this is back in July of 2020 when we were studying this. So again, here's the full model that I'll go through again. Again, with this chart, it's kind of hard to really see what's going on. So therefore, I'm going to break it out separately into this one and talk through it. So again, before we were looking at COVID cases, now we're looking at the death rates. And so with the full model, you see similar variables that we saw before with the cases model. So the percent, age was a factor, race was a factor, citizenship, percent on food stamps, and the weather, but now we had percent with no insurance was a factor on here. Now break it out again into the boroughs and examine the differences that are happening here. Again, you see different things. Again, focusing on Manhattan and the Bronx, because that's where we saw the great discrepancies when we're looking at the map. You see that very different variables were predictors for death rates for COVID-19. So in Manhattan, age, citizenship, and your health, meaning you had asthma, were predictors. But in the Bronx, it was race and the ozone layer were predictors. So conclusion, so what did we learn from this? So in both the analysis that we did with the cases and the analysis we did with the death, the age was a significant factor. And that's something you heard back then on the news as well for a while, that age was going to be a significant factor of people who either had caught COVID-19 or died from the disease. For the case rates, the portion rises for white and level ozone were the most significant predictors. And for the death rates, the citizenship, the asthma ER visits, and the proportion on food stamps. So what did this mean? So in going through all of this, again, I left out some of the modeling notes, but in going through this, we did see differences between the boroughs. And so as the New York City government was trying to allocate resources, it shouldn't be a one size fit all. It should be looking more what's happening inside the boroughs when trying to distribute resources. There were a lot of limitations for this when we did. So again, I gotta take you back to the time. I mean, this was again in June as soon as we started this. It was July when we were collecting the data, very early COVID data that we were studying. Although probably analysis is what we actually do know now. I mean, there've been a lot of studies since then that people have done studying the COVID-19 data. And so we did come up with some of the same results that a lot of other researchers have found out since then. But in our barriers that we had at the time, again, there were a lot of things happening. You know, we were on lockdown. You know, it was hard to determine who was actually following these guidelines of lockdown, who was not. Which in a spatial data set, how you move actually matters. You know, who you're connected with, how close you are to someone else, it actually matters. So those factors we couldn't measure easily. Back then, reliability tests. So remember, not a lot of people were actually getting tested back then. And if you were getting tested, these were new tests, so there were high false positives and false negatives that were happening. And then just the accessibility of getting tested. You know, not a lot of people were traveling. No one wanted to actually go to hospitals. People who were getting tested were ones that were already getting sick or ones that were very sick. I mean, you weren't going to the hospital then unless you absolutely had to. So all those factors impacted the data that we actually had to study. And as I mentioned earlier, with any statistical study, your analysis only as good as the quality of data that you actually have. So it was really hard getting really good data at the time. And I talked earlier also how we actually get data. And one source was early indicators such as hospitals and over the counter, all that. Well, when New York was collecting these data, when I talk about a messy data set, these were very messy data. We spent a lot of time trying to clean these data, try to interpret them, because again, stuff was happening so fast back then. So trying to actually get the data in a good format was kind of hard at that time. So some future work, some future things the students have been working on, and if we continue this, is we have by far better data now when it comes to who's getting tested, and the false positives and the false negatives are as much of a problem as they were back then. So there are better models now that can be built on this. We had some surprising variables that happened then that people haven't studied, such as the food variables, percent of food stamp, percent in your grocery stores, and maybe trying to figure out what those factors were. Early on, when this is being studied, you all recall they were saying that race was a big factor, being African American was a big factor in getting COVID-19. Well, it turned out, no, it's more a vitamin D deficiency, which was the bigger factor. So having a vitamin D deficiency was correlated to being African Americans. A lot of African Americans do have vitamin D deficiency, but not directly correlated with the race. So we've learned a lot more from this COVID-19 data since we did back in July. And so again, our recommendation for this work is that, again, that if you're, in New York City and in other areas, that you have to look at smaller areas when you're trying to divide up resources and not make this one size fits all overall plan for giving out resources. So those are some of the references that I use. And again, this is a really interesting project that I worked on, and we have another follow-up paper that we did, but this was published way back in at the end of 2020 when we did this. But I have to give a shout out to the part I mentioned earlier. I do spend a lot of time training students how to do research now. And so I am leading a summer RU called Spiral 2022. So if you have students that are interested, or any students are on here, the website is www.spatialru.org. So we'd be happy to have some students join if you're interested. And I have to thank all my sponsors for this research. Mainly, we had a grant from national security agencies and funding from MAA, American University, and the Delta Kappa Gamma International Education Foundation. So thank you.
Thank you, Dr. Jackson. That was wonderful. Let's go ahead and thank our speaker to the extent that we can. You're welcome to put some comments in the chat. As I said, we do have time for questions now. So if you do have a question that you'd like to ask Dr. Jackson, you can use the Q&A button at the bottom of your screen, or I can try to follow the chat as well. So let me just see if there are any questions. So there is one. So there's a question in the chat from Dr. Ortega. Can you talk about your experience leading students in this type of research at a time when data was sparse and the epidemiology of the disease was still unknown?
Sure, that's a great question. And when I think back to that time, I'm surprised we actually did this project. Those of you that teach undergraduates how to do research, you kind of want to have a little general idea of where the research is going to go. You want to make sure they have a successful project. But back then, this was so early. I had no idea what was happening then. But me being a spatial statistician, waiting for a disease data set like this, we had to do this. But we did this project, and we finished in 3 weeks. I had them for 8 weeks. They stayed on for another 4 weeks because we were virtual. The program was supposed to be face-to-face. We ended up going virtual to do it. So they ended up staying on for an extra 4 weeks. But not knowing where to start, and this was a true research project. We were watching the news, we were reading papers, we were following National Cancer Institute and CDC, looking at their recommendations, which were changing every single day. And the students, they were gathering data, they were cleaning data, and it was quite challenging. So I never recommend faculty, if you're going to work with undergraduates, to do a project like this one. That was so out there that anything could happen. But as I mentioned, I was so proud of them because they did stick with it. And again, when we first published this paper, we didn't know if these results were actually correct. Now that it's been a year since then, and so many more papers have came out that kind of back the results we have. Very, very proud of them. But it wasn't a daily program. I still download COVID data most days. I still look at it every day. They were looking at literally every day, several times a day, contacting your health department, getting it downloaded every single day, and just looking at the trends individually on that. So it was an exciting time that we were actually doing this, and I'm so glad that it actually worked out the way it did.
Great. I'm looking to see if there are any other follow-up questions. So there's one from Dr. Blackman. So the question is, well, first of all, excellent talk. The Borough forms a natural region of analysis. Are there any technical parameters for delineating the regions of analysis?
Yeah, that's good. So in spatial analysis, in the type analysis I do, which is the aerial or the regional data, you do need boundaries. It does not have to be a predefined boundary like a county or borough or zip code, but it works best to use those data because, again, you need to collect variables on those data. And so The US Census Bureau collects, there's a ton of data that already exists based on census tract. New York, the health department, a lot of your health departments collect data based just on your address and where you live. If you can get individual data on all your variables, you can define your regions how you want to do. And that sometimes is best. I didn't mention earlier, but when I showed you the California map, when we were looking at the counties of California, actually studying counties in California, it's not actually work because most of the state's population in California, over a quarter lives in LA County. And so LA County in any spatial analysis, if you use it together compared to all the other counties, you will get an outlier. So, and because it becomes an outlier, it will ruin the rates in any neighboring region. So actually, when I do study LA data or study California, I actually end up breaking LA up into much smaller, my own predefined regions. And so it's an extra step that you have to have. But you don't have to use these predefined regions. You just need some mechanism to be able to define the regions the way that you want. The other good thing about using predefined regions, if you're doing a recommendation, so I had a grant to do that California project when I was at National Cancer Institute. The state health department, they were looking for a recommendation. And so again, the way financial resources are divided up, it's better if we could tell them, this county should get this resource, this county should get the other resource. So sometimes like that, it's best to keep it in these predefined regions, but you don't have to.
I actually had a follow-up question to that. I was wondering if, and you've sort of answered my question a bit, if there are certain types of regions that provide greater challenges to the analysis that you're doing. And also, are there ever times in your research where, by way of your analysis, you have some sort of sense of that there's a better way to break up a region that actually might help understand the public health landscape better?
Yeah, those are both great questions. So for the region, so spatial data, I keep stressing neighbors matter. Who you're around matters because they're geographic trends. So in doing spatial analysis, I often study data in the US. Well, if you're in a state that does not have neighbors, so you're on the coast, like California, county around California, or Montana, or Maine, you lose a lot of valuable information to do any type of analysis there. So sometimes when I do studies like that, you may form this guard region where you end up removing counties that are along your edges so that you can have better estimates for the rest of your data set there. So you kind of end up having to throw away some of your data, but it gives your other locations more stable predictors. Another bad thing that happens in spatial data analysis is that if you're studying data, say I study cancers, and say I'm in a rural area and I'm looking at rates, and there's one person there has this rare cancer, they decide to leave to go get treatment in a bigger city someplace else, the rate drops. It can go, because the area is rural, it'll drop significantly, again, which will change. It'll make the rates unstable in all the neighboring institutions. So you have to look again, not just the rates, but actually what the cases actually look like. So if one or two people moving can change your rates drastically, that totally can mess up what a spatial analysis happens. Another big thing I mentioned with the California one, I looked at how close people live to the highway. How you measure those distances matters. I measure them in that study the way kind of like a bird would fly. It's, we use Euclidean distances, so it's easier. But if people don't drive that way, you have to turn down. There's traffic lights, you turn on roads. So living the same distance apart from a facility, does that mean it takes the exact same amount of time? So those are some things obstacles that can happen in spatial analysis and kind of make the analysis a little bit trickier.
Great, thank you. There was another question in the chat. It was actually about spiral REU. And the question was, how do the students in your REU choose their topics?
So typically I give them projects. So I will have maybe starting out 4 or 5 different projects, and I'll guide them around with the project. Because again, these are undergrad students and you kind of want to make it worthwhile for them. I kind of want to know where we're going to go. A lot of times I will have done maybe a little bit of pre-analysis just to help them with the data. But again, this year I let them start with their own project. And I did it also last year. I let them do their analysis. So I'm kind of on this new trend where I actually may start letting them pick that project. Because the undergrad, you want to keep them involved and invest in the project. And so it's much easier to do that when they do pick the project. But the downside is that you don't know what it's going to lead to. And so my funders definitely want the project published. And so we kind of put some boundaries on them. But for the most part, I always tell people when you start RU, start with something more that you kind of know what's going to happen.
Makes sense. So there's another question in the chat from Dr. Cooper, who asks, would you please repeat what you said about why a standard approach can draw the same wrong conclusion twice or something along those lines?
Yeah, so I said earlier, so a lot of times, so this same analysis, if you're not a spatial statistician, you're not aware of the spatial methods, you may have tried to just do a regular regression analysis for these types of data. If you do that, you do get the wrong analysis. You get fooled twice, I say, with your data. And so you'll end up thinking, say, that you have significant predictors or correlations when they don't actually exist. You actually end up modeling the geographic trends instead of the actual correlation between the variables. And so you end up believing if you use classical statistical methods and not take into account the geographic trends or geographic correlation exists, you'll think that two variables are highly correlated together, and you'll think that they have a very strong correlation together when they actually don't. You have to remove the geographic trend. So there's a way in spatial stats, you pull out that geographic trend, that spatial correlation. Then you examine the variables with everything that's left to see if there really is a true correlation there that's happening. It's a common mistake that happens a lot in statistics because not a lot of people are actually thinking about it. Is extra step. It's a complicated step. There's not a lot of easy ways to do it. There's not a lot of pre-built software methods to do it. Classic methods, software like SPSS everyone uses and Excel and all that can't do this for you. You have to kind of program it. So it is something, a common mistake that happens in statistics.
So I do have one more question. I'll just put it out there to our audience that if you still have a question, we have a little bit of time left, so feel free to put it in the chat or in the Q&A. The question I have for you actually is about students. If a student is interested in learning more about geospatial statistics, and they're an undergraduate, say, but they haven't attended an RU, what's some of the background that you would recommend for a student to be prepared to engage in research in this area? Or do you have any recommendations about courses or some introductory reading? Like, how difficult is it for an undergraduate to get involved in this kind of research? Yeah,
sure. So to get involved in spatial stats, I always tell students the more math classes you have, better it's going to be, because again, it's not a fully developed area like classical stat methods are. So you end up having to do a lot of this on your own, a lot of the theory and everything and figuring out on your own. So the more math classes you have, the more you can individually manipulate the models yourself and not have to worry about software packages doing this for you. So any theoretical math classes will help you with that. Most people, if you're going to take a spatial stats class, it wouldn't happen until late undergraduate and maybe even graduate. There are not that many programs that even have a spatial stats class. So having a stat background, any stat background is useful, not necessary, but it's useful. I always tell everyone, I learned spatial stats before I learned classical stats. I did it backwards. I ended up just going to a talk with a spatial statistician, and then I jumped right in on this. So I learned how to do this first before I learned the classical stats. So it comes second nature for me, but it's not the typical way that people actually learn to do this method. But as I said, the more math you have, always is going to be the better, because then you don't have to rely on what people have already done in the field.
Great, thank you. That's great advice.